Hello, I'm Bradley Stoner. I'm the Secretary of IUSD Canada, and it is my privilege to be the moderator for today's webinar entitled Genital Herpes is Still an Important Issue in 2023. Our guests today are Dr. William Fisher and Dr. Mark Stebbin. First, about Dr. Fisher. Dr. William Fisher is Distinguished Professor Emeritus at Western University, having spent 4 decades in the Department of Psychology, cross-appointed to the Department of Obstetrics and Gynaecology at Western University. His work focuses on understanding and promoting sexual and reproductive health in the areas of individual and couple sexual function, contraceptive choice and adherence, STI/HIV prevention, sexual pharmacology development, and the education of healthcare professionals in these domains. Dr. Mark Stebbin is a family physician and president of IUSD Canada, and also president-elect of the International Society for STD Research, as well as chair of the 2025 World STI Congress of the ISSTDR and IUSD World. As a family physician, Dr. Stebbin concentrates his clinical interest on sexual health, mainly chronic genital diseases. We'll go ahead and get started today. I cede the stage to Dr. Fisher. Take it away, Dr. Fisher.
Thanks very much for the introduction, and thanks particularly to those in attendance. Genital herpes indeed remains an important concern. And my approach to it really descends from my general interest in chronic carriage of viral STIs, including HPV, HSV, and HIV. One of the things that we note in Canada, I like to say, is that demographic and sexual behavior changes really alter the clinical landscape. The short version of that into English is that the average age of sexual debut really hasn't changed. People are phasing on their sexual activity at 16 or 17 or 18 in general, but they're not getting married until their early 30s. And there is an extended window of vulnerability for the accumulation of sexually driven pathogens. And that creates a setting where not only do people acquire viral STIs, in this case, herpes, but they also deal with a behavioral context where they carry it with them, they have to disclose it, and they have to live with it for a very long period of time. Now, I'd like to share with you an illustration of the value, indeed the obligation, the need, the benefit of counseling people who have herpes, who have a herpes diagnosis. And I'll do this sharing my screen with you if I can master the technology here. Okay. Now, this is very, very timely in the age of COVID and Zoom, although this actually happened before the pandemic. In this case, of a young woman who turns to me via an ancient email in order to preserve her anonymity, surfaces a whole bunch of important counseling challenges, and I thought I'd share it with you. Dear Dr. Fisher, I'm using this email for now instead of my usual email to try to keep this anonymous. I feel a little more comfortable writing you from my ancient Hotmail account. There's a lot of stigma, a lot of shame in counseling conversations, and this comes to the surface right away. I was recently diagnosed with genital herpes HSV1. I have a lot of questions and have tried researching them, but have not been able to get many answers. I'm hoping you may know some of these answers or know someone who I may be able to ask. So this is a classic and unfortunately kind of a common a reflection on information deficits post-diagnosis. So here's a bright young woman. She has a lot of concerns, and she hasn't really been able to get some very foundational answers. But she's, looking, and we're having this counseling exchange actually via internet. I was diagnosed in June. I'm not sure who I contracted it from. I've told my boyfriend, and being a great guy, he stood by me through everything and has decided to remain with me. So we, see immediately the relationship challenge of a herpes diagnosis. According to the doctors, it's most likely I got it from him, even though he's never had symptoms. So who knows? One of the things that she may need reassurance about is that it's really difficult to tell where an infection may have come from. Going forward, my boyfriend and I are using condoms to prevent the risk of transmission. We're not ruling out the chance that he's infected as well, and also not putting him at risk for infection in case he isn't. My clinical sensitivity was engaged by the words prevent the risk of infection because informed decision-making really would position preventive strategies more in the domain of reducing the risk of prevention. And I might, in a nuanced way, introduce that language. So here are her concerns. Previously, my partner and I enjoyed oral sex. We haven't done it at all since the diagnosis, and it's a constant reminder to me that I'm infected. So we have, a sexual pleasure deficit that, she feels may be moving forward. And it's also a constant reminder that she's infected. The doctors had briefly mentioned to me suppressive therapy, but scared me out of considering it. They basically said, if I use it, I'm going to suffer liver failure. My sex life hasn't been nearly the same since this happened, and it's really upset me. Is there any way to try to reduce the risk of transmission and return things to how they were before? That would be a bonus. Again, this is common, hoped for, and we try to manage expectations, but provide reassurance that things will get better. This is a manageable infection, and your sex life will probably rebound. Eventually, someday I'd like to have children. I realize that I can have kids if I'm pregnant, just that I'd have to have a C-section if I had an outbreak during delivery. But what about getting pregnant in the first place? Because I'm doomed to use a condom for the rest of my life. How am I supposed to get pregnant? With a turkey baster? Again, I would have hoped that, counseling around and even better in a follow-up appointment after diagnosis would have provided her with an opportunity for managing this concern, but it hasn't. It would be extremely helpful to know if my boyfriend does or does not have the virus. And if he does already have the antibodies in his system, does that mean he's less likely to become infected by me? Again, this is a rich and complex issue that I and I think Dr. Staben will also deal with. Every time we've asked to get tested, doctors have denied us. If he's negative, then we know for sure we need to be 100% careful. Again, this is surfacing a rich, important counseling issue that could have been addressed, should have been addressed, but hasn't been addressed. This young lady is hanging in the wind. Before I got diagnosed, I thought I was being careful, and I was definitely uninformed about herpes, even though I assumed I was educated about STDs. I was very careful about sex and have only had 2 sex partners in my history. One of several years that I had tested before I agreed to do anything with, and the other, we were committed to each other before we agreed to any sexual activity. So there's 2 heuristics here, 2 decision rules. One partner, we got tested, although she didn't know that STI testing doesn't include herpes testing. And the other heuristic is, I knew and trusted this guy, and that presumably is an effective prophylactic for all sexually transmitted pathogens. My partners had only had 1 or 2 other sexual partners themselves. In the 1980s, the US Surgeon General sent a letter to every US household advising people to get to know their partner's sexual history. Perhaps this young woman or her parents or her teachers had picked up on that, but there's actually a simpler decision rule. If your partner has a sexual history, you have to use actually effective preventive maneuvers. There's no way to know from a sexual history whether your partner has a sexually transmitted chronic carriage viral pathogen. My partners had only had 1 or 2 other sex partners themselves. I sort of always assumed more promiscuous girls were more likely to get it, or guys with lots of sexual partners. I didn't know that herpes can lie dormant for years, didn't know that STD tests don't test for herpes, didn't know that a condom is not effective in preventing the spread of herpes. So this one rich case, and I'm very grateful to this woman for turning to me and actually doing it in writing, surfaces, I'm tempted to say almost all the issues that are common in counseling challenges in this area. Of course, it's not all the issues. There are many other issues, many other presentations, but it's a good place to start. So I had a conversation with this young woman that involved a whole bunch of messages. The first thing I did was I, thanked her for verbalizing her concerns. I tried to let her know that I deal with these questions all the time, that herpes is extremely common, that maybe 1 out of 6 people have herpes virus infection. Almost none of them know it unless they get an outbreak. They misinterpret it, they may never get an outbreak, etc. It's really, really common, and it's important to talk to the right people and get information. This is a manageable concern, and it's common, and let's deal with it. It's pretty difficult to know where herpes comes from. Herpes virus can live without producing symptoms for a very, very long time. Your current partner has never had symptoms of which he's aware. It might have come from him. It might have been a historical infection from the past. It doesn't really require penis and vagina intercourse. It can come from oral sex. It can even come from lubricating your finger and massaging your clitoris or whatever. So it's difficult to know where it comes from. I'm pleased to know that you had a diagnosis that included an HSV type. I talked about the fact that HSV-1 outbreaks are relatively uncommon. You can't be certain. We know they're less common than infections with HSV-2. You may never have a recurrence, or you may have infrequent recurrences, and that's good news for you. You've been misinformed with respect to the safety of suppressive therapy. Suppressive therapy is safe, and I need to correct that bit of misinformation. It's safe if you need it, and it's safe if you want it. Need can be signaled by many recurrences that are difficult to manage medically and personally speaking, although that's relatively unlikely in the case of HSV-1 infection. But it can also be used if you desire it. If as part of your management within a relationship or within subsequent relationships, it becomes desirable for you, that is an option for you to reduce but not eliminate risk of transmission. I always do a bit of cognitive restructuring. Herpes sounds awful, but herpes are cold sores. And I often find that thinking a little bit differently about herpes as cold sores who have regrettably relocated to an inconvenient piece of real estate may be a bit helpful, She was very, very upset that the medical establishment, as she put it, has denied her the partner serologic testing in the case of an asymptomatic partner. And I think Dr. Steben will go into why this is not going to be particularly diagnostic in the case of an asymptomatic partner who's never had an outbreak, what the meaning of finding HSV-1 antibodies that may result from oral labial infection is not going to be very clear in this relationship. We talked about disclosure. She was very, very concerned. She talked in subsequent exchanges about, gee, do I have to stay in this relationship? I'm happy now, but what about my next relationship if this isn't my last relationship? What about other women who may feel forced to stay in bad relationships or abusive relationships because they're worried about disclosure? They'll never get another date. We talk generally about disclosure and waiting until a certain amount of security in a relationship has begun to develop. One suggested disclosure strategy hitching a ride on the fact that she had asked partners to undergo STI testing in the past, one suggested disclosure strategy actually would be to say, look, before we have sex, I think we should discuss STI testing. Have you been tested? What is your STI testing status? And then use that discussion to say, look, I've been tested and I have the virus that causes herpes. I find that talking about the virus that causes herpes is somehow a little bit less problematic than I have herpes. And indeed, the woman has the virus that causes herpes, and that's what she has. So one maneuver involves talking to your partner about their STI status and then exchanging information about yours, having set the terms of the discussion. The young woman was, a high libido, young adult woman who really enjoyed sex. She enjoyed oral sex, she enjoyed her sex life, and now it's really been damped down. So, I'm thrilled to suggest sexual adaptations. There are new clitoral vibrator suckers that exist. You can purchase them on Amazon.com in place of receiving oral sex. You can have oral sex on a partner with a condom. I talked to her about dental dams, and I said, forget about ordering them from a dental supply house. Buy yourself a couple of unlubricated condoms or lubricated condoms, snip them down the middle, and you've got a latex barrier. And you and your partner can actually use this as an excuse, if you will, to explore online sex shops and start to augment your sex life, keeping your sex toys carefully covered with condoms and not sharing them, etc. I'm lucky enough to practice in an environment with sophisticated sexually trained psychologists, sex therapists, and support groups, herpes support group referrals if she needed it. She didn't know how she was going to have a pregnancy. I deal with this very, very often with HIV patients. Basically, the message I gave her was you don't have to use a turkey baster, although, artificial insemination is a possibility, but conceiving a pregnancy during a period of suppressive therapy, is one reasonable adaptation. I also pointed out that in my experience, there's significant adaptation and improvement over time, and there won't be an after, but there will be improvement. Now, it's really important, I think, to provide some follow-up counseling as well. The young woman I spoke with was kind of in an acute phase. She was distressed, not clear to me that it was the perfect time for information exchange, so we had a follow-up interaction. And at the end of the interaction, she wrote to me, I'm dealing a lot better with my situation since my original email largely brought about upon the support of the people I chose to share the news with and with the information I got through you. The realization that life will and has continued on as it did before, for the most part, helps in dealing with this. I still have a lot of anxiety in relation to the possibility of a future outbreak, not knowing when it may come, how bad it will be, and being perhaps too much aware of the signs that another outbreak is coming. So this survived the reassurance about the natural history of HSV1. She is an anxious person. The only other source of anxiety is associated with fear surrounding the idea of even entering the dating scene again. And even though I'm in a happy relationship, there's a lot of pressure to make sure this relationship works out, just to avoid finding someone else while having an STI. I see this as not so problematic for me personally. I think she benefited from our disclosure discussion, but I could see how some women may be influenced to stay in an abusive relationship because of this. Also, upon talking with some friends, I found out about one who had a run-in with a treatable STI in the past, and another who had a friend who had gotten genital warts. hearing that I'm not the only one who was sort of helpful. And as it turns out, my story has convinced all of my friends to consistently use condoms, so that's a silver lining as well, as much worse STIs are out there, and I would hate to have any of my friends catch them. Only other thing I could think of is that there's still a minor effect on my sex life, as oral sex is still off limit and was previously enjoyed, but most other things remain the same. So I think it's pretty clear that there are challenges, many of them quite typical in counseling around an HSV diagnosis. One thing you can do is to zero in on concerns. Some people say, do you have any questions? I prefer to say, what are your concerns? And we can discuss them rather than assume that concerns A, B, C, F, G, H, and Z exist. I find it helpful to say, what are your concerns? And that can help me zero in on a supportive discussion and an informative discussion. She listed her concerns. That was very helpful. I'd strongly advise you to take 15 minutes and a cup of coffee to read the counseling tool that is online with the Canadian STI Guidelines under the PHAC auspices. It's a 15-minute read. I find the FAQ particularly helpful. And with that, I'm going to turn the floor over to my colleague, Dr. Steuben.
Thanks, Bill. I'm going to share my screen. Good. So I'll start by disclosing my potential conflict of interest. So in the herpes world, I have very little at this moment a discussion with Gynaecology that we're developing a therapeutic vaccine, but that is the only issue with HSV in my potential conflict of interest. So I thought that starting with some of the studies we had in Canada, a lot of them were published in journals that did not reach a lot of the Canadian experts about STIs. So starting back, there was a study that was done by David Patrick in British Columbia, and it was done on pregnant women from the age of 15 to 44. And they were able to do the HSV1 and HSV2 tests. And we see that in pregnant women, it was almost 60% seropositivity that was seen for HSV1 and 17% for HSV2. Howard in Ontario, this was a skewed population a little bit. So there were men, there were pregnant women, and a lot of the other people that fill the numbers were employees of the hospital and the clinics. So it's not a population at large, but we still see that there was 40% of men that had HSV1 compared to almost 70% of pregnant women. So this is not a rare occurrence. And non-pregnant women, 52%. And the overall seropositivity for type 1 was 51. And when we look for herpes type 2, it was 9%. After that, Amita Singh in Alberta that work in STD clinic, they had a huge number of patients, 6,555. They had 56% HSV1 seropositivity and HSV2 19%. But this is an STI clinic. This is not, again, in the general population. But a little bit later, there was a study that was done across Canada. It was embedded in the 2009 to 2011 Canadian Health Measures Survey. And they were testing for both chlamydia and herpes simplex type 2. No test for herpes simplex type 1. and it was estimated the HSV rate on 3,247 respondents age 14 to 59. And we can see in total, we had an overall seropositivity for HSV2 of 13.6% for people from the age of 14 to 59. There was not a lot of herpes type 2 in the younger group, 14 to 34, but we could see 35 to 59, much higher. And of course, as you age, you can have more partner. You cannot have less partner in the future. And we see that there were 15% of people that were married, cohabiting, not married. So that is the data they have. They were able to see also the household income, and it was pretty well distributed in the general population. And we look for the difference in education, not a lot of difference. Where we saw difference was with race, white and non-white. There was a significant difference between the two groups. When we compare male to female, we see that women have more seropositivity than men. And this is true at all ages. So this is the only population-wide study that was done across Canada about herpes serology, and it was only for type 2. When we look at the percentage of people that did not know they had herpes type 2, it was very high. And you look, 99% of people that had herpes type 2 serology did not know, and going down to 93 and 92 for the 50 to 59 year old. Male more frequently in the older age did not know compared to women. So this is a little bit like the NAINS study that was published by Fleming in the New England Journal, where they had 90% of people with herpes type 2 serology positivity that did not know they had the disease. We did another study, and it was looking at pharma, the coupons people give to pharmacy for prescription. And we look at the prescription in a data bank, and we look at the period between 2002, 2007. And we were able to see that there would have been between 85,000 and 122,000 people that had a case that would be attended by a physician writing a prescription that year. And when you look at the mean visit per year to a doctor, 74 to 93% of people with genital herpes made one visit per year at the mean. And when we look at the general population, we were able to calculate that the rate of HSV, genital HSV that was seen by doctor would be between 261 and 386 per 100,000 population per year. So that's a significant number of patients that are seeing doctors in Canada. Another study that we did also with the help of PHAC was neonatal herpes surveillance. So that was done with the help of the Canadian Pediatric Society. And we saw that there were 58 cases in 3 years that were diagnosed of neonatal herpes. We were careful to eliminate duplicate and triplicate notification in the project, and it gives an incidence of 5.9 per 100,000 live births in Canada. Quebec had more cases, 8.6 per 100,000 live births. The mean age of women delivering with a kid acquiring neonatal herpes was 26. 76% were white, 25% a C-section. So we thought that C-section was very safe. Still, some baby can be infected through the placenta or after the amnios has ruptured. 28% of these babies were premature, 28% had low birth weight, and only 40% did not know they had genital herpes, and only one baby had lesion at delivery. We did publish a little bit later the complication rate after 3 years of follow-up to see there's significant burden from neonatal herpes in those kids. When we look at all the cases, 62% were caused by HSV-1. This was strikingly different from data published in United States with Zane Brown in Washington State. Localized disease was the main clinical picture, almost 60%, disseminated 17%, and central nervous disease 22%. So now I go with an article that discussed the importance of HSV-1 in genital herpes. So there's a publication that was led by Christine Johnson, a researcher in the field of genital herpes for a very long time. And they were able to capture 82 participants that had a primary herpes type 1 genital infection. They also made sure they did not have herpes type 2, and they did not have HIV. And the mean age was 26, and 66%, 2/3 were women. 42%, 42 cases, that was 50%, had primary HSV-1 infection. So the serology at the time of presentation was already positive for HSV-1. And non-primary would be people that already had herpes type 1. So I think in terms of the follow-up, especially in pregnancy, it will be important to know those that are a true first infection and not an infection that is new to the genital tract, but that person previously had oral labial infection. So when they followed these patients at 2 months, they were able to see, to find by PCR that 65% of people had detectable HSV-1. So they look like they're continuously infected at the start of the infection. And they found 30% in the mouth. And it's very difficult to know if those herpes that was detected in the mouth came from the same infection that was acquired in the genital area. So, and after that, you see there's a slow decrease at 12 months. So the follow-up, and it was much lower at 11 months. So it made the authors say that you're highly infectious, early stage after infection, but that the infection shedding is getting very low after 1 year. And when we compare person that had primary HSV-1 infection, those that were HSV-1 seronegative at the start of the study, they had much higher shedding than those that already had herpes type 1 antibody in their bloodstream. So 7.9% compared to 2.9%. There was an editorial that accompanied this paper, and it was done by two of the most expert American on the herpes issue. And they were able make a good discussion about serological tests. And we know that there's a huge difference in the shedding patterns, the clinical manifestation and management between genital herpes type 1 and type 2. There's very little cases that compare both infection in terms of acute, primary, acute, non-primary, and also recurrent disease. And the big problem we have is that the serology kits that are available usually are pretty good for herpes type 2, but are not very good, and they perform relatively poorly for HSV1. And also, when you have a serology for herpes type 2, very unlikely that this would represent an infection that is occurring outside the anogenital tract. But with herpes type 1, you never know if this comes from an orolabial infection, anogenital infection, or both. So at this moment, we have limited use of herpes type 1. It's already bad test, and it's also not helping us in differentiating the type of infection that is occurring. And there are guidelines for the management of herpes type 2, but very little is discussed about herpes type 1. So we need more research done on herpes type 1. We know that symptomatic recurrences were much less frequently told by patient than herpes type 2, so that is well known. And the data they have in the paper validate that the risk of genital herpes type 1 may decline rapidly following initial infection, but it's never zero. We don't have a test that can tell us if a person will be shedding asymptomatically herpes type 1 and would be contagious to a sexual partner. So for clinician, it emphasizes the importance of determining the viral type in a person that is presenting with not only initial episode of genital herpes, but any occasion that a patient doesn't have a confirmation of herpes simplex infection. And of course, if they don't have confirmation, they don't know what type they are infected with, because the difference between type 1 and type 2, there's the risk of clinical recurrence that is much higher with type 2. The likelihood of asymptomatic shedding and transmission is much higher with herpes type 2. And we have good data about antiviral prophylaxis with the study that was done with valacyclovir 500 milligram on a daily basis. And at this moment, the best test would be not testing, PCR testing, and not serological testing for determining the viral type. A little look now at US Preventive Task Force that emitted a recommendation about screening. So we know that when a decision is made to have a screening, we usually use the criteria of Wilson and Junkner. So the condition should be an important health problem. So herpes, I think, is important. It should be an accepted treatment. As Bill said, that not only is an accepted treatment, it's a very safe. It's one of the safest drugs you will ever prescribe in your life. Facilities for diagnosis and treatment should be available. And I think that is maybe a weakness in the STD world. Not a lot of people are given the right counseling tools to do good counseling about the diagnosis, treatment, prevention of transmission. There should be a recognizable latent or early symptomatic stage, not in this case. There should be a suitable test or examination, and this is completely false. We know that herpes serology is one of the worst serology we can have in the infectious disease world. The test should be acceptable to the population. There's too much uncertainty for this test to be acceptable. The natural history of the condition is known. So we know for herpes type 2, not for herpes type 1. There should be an agreed policy on whom to treat as patient. We have an agreement for treatment of acute genital herpes or recurrent genital herpes, but we don't necessarily have one to decrease the transmission to a sexual partner, especially if it's a type 1 infection. The cost of case finding should be economically balanced. We don't know that. We didn't do studies on the economic side of doing prophylaxis. And case finding should be a continuing process and not a once for all project. So we see that herpes serology screening doesn't fit the Wilson and Schuckner principles. There are key messages. Screening may bring benefits to some people, but it can also bring harm. Counseling that is not appropriate, as we could see from Bill's reading the letter he received. And it's not because it can be done that it should be done. And is there resources be better used in other ways? I think that the counseling we give to people with HSV infection should be optimized and certainly more about the prevention of transmission. So there's no population screening, of course, with what we've said. And Wilson screening principle remain the gold standard when deciding, and we're not achieving the level of strength that is needed for the screening. So a few years ago, I did an article for the family physician in Quebec. It was in French, and PHAC got the text translated. So it was about tips, pitfalls, and misconception about serology for herpes simplex virus. So you can just type INSPQ serology for herpes simplex virus, and you'll be taken to the article. And one of the most important table that is in the article is a table that was published by Schoolar, and it's about the evidence base on the genital herpes, optimizing the use of diagnostic tests and information provision. And people fail to appreciate the fact that when we are screening in a low prevalence population, there's such a huge risk for tests that will not give a good positive predictive value. And we can see that if we have good negative predictive value with herpes, considering a sensitivity of 95% and a specificity of 98%, the positive predictive value is very bad in low-risk population. And of course, if you go to a high-risk population, then you get better PPV, but certainly not perfect PPV. And the risk of a false positive will be 29% in the lowest risk population and will be still 10% in the high-risk population. So for the herpes serology, so I gave it a red light in the article. So the ideal screening period is unknown because the time to seroconversion may exceed 3 months. And there are people that were found to have herpes type 2 infection that are still seronegative after 1 year. Only 72% of patients with primary herpes type 1 will seroconvert at 3 months. 73% of those with non-primary HSV2 infection will seroconvert at 3 months. And 93% of those with primary herpes type 2 will obtain positive result while with existing serologic tests after 3 months. This is absolutely not at a level that we should be using for a screening test. And we have to be very careful also to use that as a diagnostic test to prove that what happened with that lesion on the vulva or that lesion on the penis was genital herpes, because this ideal screening period is unknown. So I was interested by an article in JAMA that was from the U.S. Preventive Service Task Force, and it was recommending in 2016, it recommended against routine serologic screening for genital herpes, including those that are pregnant. And they reconvened an expert group to revisit the recommendation, and they look at what happened since 2016. There were more than 3,000 abstracts and 64 full-text articles that were reviewed, and no new eligible studies were identified for any key questions for the task force to reverse their recommendation. So the review, however, was focused on the general population of asymptomatic adolescent and adults, and may not be applicable to population at higher risk. And you understand that this is not to criticize the CDC recommendation that was made in 2021 in the STD control guideline. So it recommends serologic screening for specific asymptomatic populations at higher risk for infection, and they put in that category person with HIV or other immunosuppressive condition. And I think that it has to be taken with a yellow light, because there's still a lot of false negative and false positive in that group. And the major issue is that we don't have in our reference lab a confirmatory test like we have for hepatitis C, hepatitis B, syphilis, or HIV. And I think this shows that we should be a little bit more serious when we use these tests. Only the NAT testing will be a proof that there's been an infection in the lesion, and the seroprevalence of herpes type 1 and type 2 in the population is at a certain level where we cannot automatically associate a person with a history of genital lesion and the positive result as being the cause of the lesion. So we have to be prudent that only finding the virus in the lesion proves the etiology of the lesion. We can extrapolate that it may, but we cannot guarantee that it is the case with serology. I've put down Canadian resources. So the screening, there's a Canadian counseling tool for herpes, for genital herpes, and it does state that it's not recommended in people who do not have a history of anogenital lesion. There are two SOGC guidelines that were first published in 2006, and one is about gynecological aspects of genital herpes, and the other one is about the obstetrical aspects of genital herpes. Both of them were revisited, and they were readopted a few years ago with absolutely no change from the 2006 edition of those guidelines. So in summary, for the screening for herpes type 2 in asymptomatic adolescent and adults, including pregnant person, recommends against routine serologic screening for herpes simplex virus in asymptomatic people. And I think we can discuss that there's place to help us make decision in a sero-discordant couple. So when someone meet a new partner, we discuss, I'm herpes type 2, and I don't know, I never had lesion, I never had partner, and they want to know what kind of protection they should be using, daily acyclovir prophylaxis or valacyclovir prophylaxis, condom, both or none. So I think this is discussion that needs the two partners to be present at the clinic, so they can make they can take a decision. They'll be happy with the recommendation. And of course, the dynamic of prevention of transmission in a stable partnership can change when people are looking for babies. They can be much more precautious about prophylactic and as soon as the woman is confirmed being pregnant, to use condoms and to avoid oral sex certainly will help in that couple. But you see, at the beginning of a relationship, it can be both prophylactic antiviral and condoms. And after a while, they can decide not to use protection anymore. And when it's time to have babies, we go back to the full protection of condom and antiviral. So conclusion of this article that was in JAMA also. So reducing HSV2 morbidity and mortality and routine serologic screening, still not the best answer. And of course, when a test result is to be transmitted to a patient in a context that of uncertainty and hypothesis, screening should not take place. And that's the end of it. And some people are adamant to have screening, but they should understand the severe limitation that can be posed with some results. And I asked them, what would it change in your couple if we know your test results? And sometimes it's just to know, but I've seen couples separating because having the tests and facing the reality that one was positive and the other one was not, the relationship ended. So let's be careful with screening, proving the etiology when there's lesion, and properly doing the counseling to reduce the risk of transmission to a new partner or to a regular partner or a baby to be born should take our time, and not doing routine screening. So I thank you very much for your attention, and I'll give back the microphone to Brad.
Okay, thank you very much, Dr. Fisher and Dr. Stebbin. Very interesting presentations. You've raised a lot of important issues. We do have a few time for a few questions. We'll go right to the chat or to the Q&A. And Victoria Ralph asks, I had a patient with cold sores recently who had a lot of questions surrounding spread to genital herpes. For patients with history but no current oral lesions present from HSV1, is there still a risk of spread to the genitals? Dr. Fisher, you kind of addressed this in your remarks. Do you want to take that question? Oh, I think you're muted, Dr. Fisher. We can't hear you.
Okay. I think it's an important question, and it's a common one, and there's no perfect answer. To tell an individual with oral labial herpes with cold sores, they can never again have oral sex when this is a modal, very, very common form of sexual expression in a population where maybe 70 or 80% of the population has a history of, HSV1 oral. That would be extreme. So, I'm a strong believer in informed consent. I would say that my personal judgment would be not to have oral sex during an outbreak, but the population prevalence of this is very high, and it's unlikely but not impossible that transmission will occur. But I would also bring this into there are a world of low risk but not no risk activities. This is one of them, and that's my preference. I'd be interested in what Dr. Stebbin would say.
Yeah, I leave it to the couple to discuss between themselves. Would they like, to be so protected that the only thing they can have is penetration with a condom and no rubbing around, no kissing, no touching, and they can go to all the different activities they want. So I think it's up to them to set where the level of comfort and discomfort will be optimal for the two in the couple. In the first few months, frequently it's antiviral and the use of condom, and after a while they abandon the condom, but they keep the antiviral. We know that the antiviral is very good. The big problem is the study was not done at the right dosage, and no one wants to do the study with a better dosage. We know that also the fact that was hidden in the publication is that the best protection against transmission was the
got a glitch, Dr. Stebbin. Little bit of a hiccup.
5% of the rate that a lot of people did not obtain.
Mark, do you want to carry on and address this next question? Because you were talking about suppressive therapy. If the client opts for suppressive therapy, may she be confident that her risk of transmission with condomless or barrier-free oral sex is significantly reduced?
We don't have data for type 1, but we know that the risk of transmission from those people that took less than 95% compared to those that took 95% and above is at least 75% reduced. And that brought like an average of 1.1 transmission per 100 participants for a full year. So, you know, this is pretty safe. You know, I had a patient, she had a head trauma because she slipped out of the bed and knocked her head on the counter next to the bed. I had, you know, once a year I see a guy that is being bitten on the penis accidentally during oral sex, and all these people went back to having sex. So no risk sex is very, very rare nowadays.
You want to quickly address the issue of a duration of therapy? How long can a patient remain on antiviral medication, either Dr. Stebbin or Dr. Fisher?
Yeah, I can take the big problem with the drug. It's so safe, and people can't believe when you look at all the studies for all the conditions, CMV or shingles or for any kind of herpes type 1 or type 2 studies. Most of these studies, we see more adverse events in the placebo group than on the active drug group. I think it's not contraindicated in elderly people. There's no influence on other drug that a person may be taking. We give it to highly immunocompromised people, you know, people that are receiving heterologous cells for bone marrow transplant, their CMV discordant. They will take 6 pills per day for 6 months. So this is one of the best drug in terms of safety. I have some patients that are highly immunocompromised for many, many years and decades, and they know they're going to die with taking a drug. I have patients that are taking it for more than 25 years. You know, they're highly immunocompromised because they had a lung transplant and they're taking a handful of pills every day. But if they forget, they have huge cold sore. You know, it's half the face that is being infected in those immunocompromised patient, and takes time to heal.
There was a request to send the link to the HSV counseling recommendations mentioned in the first talk, but I think you did that already, Dr. Fisher, in the chat. Is that correct?
I sent the link in the chat. There is a hyperlink to a Katie publication that doesn't seem to be working right now. We're going to try to fix that. The internet, and I deploy this as a resource for patients as well. There are TED Talks. There are some pretty good YouTube videos about disclosure. I would say that one form of prophylaxis, which is really lacking, is a general understanding in a half-informed population of clinicians and patients that even if you get to STI testing, very, very rarely are limits of testing discussed. I've had phone calls from the hospital, from clients who, you know, their parents are in the way to the hospital. They've got, you know, severe genital herpes infection. They're in really bad shape. And they said, you know, I was tested. So I would like that information to become, you know, a little better understood. There are limits to testing that involve both continued monogamy and understanding of the limits of testing, because this is not going away.
I think we're right at the hour. That's probably going to have to be our last question and comment. As the moderator, I want to thank both of our presenters, Dr. William Fisher and Dr. Mark Stebbin, for your expert presentations today. We will be posting this presentation, the recording, on our IUSD Canada webinar. On behalf of IUSD Canada, I want to thank everyone for attending today.
Thank you.
Thank you.
Bye-bye.